And welcome to tonight's webinar. Tonight is an exciting webinar for me because we're going to talk about a particular service that's been near and dear to my heart for the past 18 plus years. Yeah, we're going to talk about periodontal endoscopy, which frankly made a tremendous difference in my practice. And we're happy to have with us as our guest, Dr. Oris Kormaninski. You know, Oris has been doing this stuff probably longer than I have. And Oris was involved in developing a new scope. He'll talk a little bit about that. We're not going to talk about the product so much. We are going to talk about the service because, frankly, it is a differentiating service. It's an effective service, and it doesn't cost you that much to be that unique in your particular area. So, Oris, thanks for joining us on the Ideas webinar.
My pleasure, Lee. Looking forward to this.
So, let's go back with some background. My background starts like 1999, 2000. Yours too, or?
Yeah, right about then. I think I was one of the first group of buyers of the periscope at that time. And Lee, I need to clarify. I did not do anything as far as developing.
You did nothing?
I did what? No, I did nothing in terms of developing. Okay. The only thing we did was basically we helped with modifications to the prototype, but that was mostly my hygienist working with Michael and Chad from AuraView on modifying. I don't have any engineering skills, and I don't like to put together bicycles that are Christmas gifts either. So.
All right, but just for the audience, you do know something about this, right?
Oh, I do know. Yes,
I do know. Pick you up off the street in Las Vegas and say, talk about this thing.
No. I do know about it, and I do know about the marketing. I do know about how we work insurance, how we talk to patients about this, and all of that stuff. So that part, the part that brings the patients in and parts that brings the revenue in, I think I can address that pretty well.
All right, terrific. So I'm ready when you are. Let's get started.
Okay, all right. So let me just go ahead and get this up here, and we'll hit.
Want to hit that? Make sure you hit your check boxes as well.
Yeah, I got that. It's automatically in there, and we shall go, and then I will hit slideshow. We'll start from the beginning. So, Lee, it was working when we did.
Yeah, during rehearsal we did fine, didn't it?
It went fine.
Always works that way. If you wanted to do presenter's view on the lower right side on the orange bar, and do presenter's view.
Oh, there it is. There it is, Lee. There it is. It was just open up down in different place. All right, so we're all set. So this is really the wave of periodontal therapy, endoscopic periodontal therapy for treating disease and periodontitis. And this, just like everything else in medicine and in dentistry, we're getting to where we're working in smaller areas and at higher magnifications. And the endoscope is allowing us to do that, to treat periodontal disease definitively without periodontal surgery. And I want to talk to the audience. I assume everyone here is a periodontist on board here, and ask you some questions. And we're all had faced all of this. When I was in practice, that my numbers were going down from referrals. Both the number of referrals and the actual number of patients per referral was going on. And this trend is what a lot of people are talking about in the periodontal community, and it's definitely on the increase. It's definitely not decreasing. And I don't know what the economy was really bad in 2008 in Arizona. I don't know what it was like in Florida or other parts of the country. I think it was everywhere was pretty bad. Everyone was talking about how slow it got, and some people have never really recovered from that. And the referral patterns that used to exist no longer exist. And in order to deal with this, I mean, you got to have a plan that goes beyond, in my opinion, it has to go beyond the traditional referral patterns, as I like to refer it to as the lunch and beg model. That one
Lunch
was
and
always
beg.
lunch and beg.
Yes.
Yeah, that you know, and
Please,
please,
please.
please, please, please. And, you know, invariably what happens is, you know, something happens with the patient, the referring doctor gets pissed off at you, and then next thing you know, they stop referring, they're referring to the person down the hall, and you spent all this time on educating, building a relationship, and it all goes for naught. And sometimes it's just for really no good reason at all. So I need to tell you just a few things about myself. I retired from clinical practice on June 1st of 2018. I've been practicing as a periodontist since '85. I finished dental school in '81. I used to be the chief medical officer for Periodontal, which is doing business as OraView. I do have an equity stake in the company still. So just to so you can take that, put that information into your calculation about what I say and what I talk about. Also, I need to say that in no way do I represent the company. Anything that I say is just my opinion, my data, and it's not a representation of periodontal or OraView. So let's talk a little bit about what happens here. When patients are told they need to get periodontal surgery, just about for anything that we do now in 2019, the first place we go to is the internet. It doesn't matter who or what, but we go to the internet. And on the internet, we know that just because it's on the internet, of course, everything is true, and it's there's no bad stuff on the internet. Well, I had a patient, and this was kind of tell a little story here. I had a lady who was, I guess you'd call her your prototypical soccer mom, and she had very, very advanced periodontal disease for her young age. And I was very, very concerned. She had about 50% bone loss for a very, very young age. And I thought she was a great candidate for endoscopic periodontal therapy, because if somebody tried to do surgery or anything else, black triangles would have existed all over the place. It would have been a horrible aesthetic mess and things like that. And so I thought we had a great consultation, and I thought she walked out of the office, she made an appointment with my manager. About 3 days later, my manager comes in and says, so-and-so canceled. And I was just like, so like, what happened? What happened? And so I was sitting, I was like, it bugged me. It was bugging me the whole day, because I thought this is not good. And if this lady gets surgery, it's going to be a nightmare to deal with. And so I called her to find out what happened. And she said, I said, you know, had the conversation about, I thought we were going to do this, and what happened? She goes, well, I went home and I thought about it, and I went to the internet, and I am going to rinse my mouth with my own urine, which was just absolutely incredible. I just like, there was nothing I could say. There was nothing I could think about.
What is the answer to that?
Yeah, there is no answer. I'm generally not a person who's at a loss for words, but when she told me that, I was just like, I was just stunned. And so of course I had to share this story with one of my colleagues. I go, do you know Bob Londonly?
I know the name, and maybe I've met him. I don't know.
Bob actually used to run.
Wait a minute, is he a prosthodontist?
No, he's a periodontist. He used to run the perio program at Nova, and also at USC.
I should know, but I don't.
But I called him and I had to tell him, and he's very deadpan kind of funny guy. And he said, well, Oris, maybe she should use your urine since you're a specialist. Just
that's good.
but you know, so a lot of stuff go on. But one of the things that happens is that when you have endoscopic periodontal therapy as a tool in your office, there are tremendous opportunities for you to grow your practice using this. And one of the things that happened is that patients would come to me clutching a referral slip to another periodontal practice, because we did non-definitive periodontal therapy without periodontal surgery. And people were looking for that. People were trying to avoid periodontal surgery because not only did they go to the internet to find out about alternatives, but of course they go to YouTube and watch some videos about periodontal surgery, which scares the hell out of them at that time. Now, one of the things that I did, I had my practice, as you know, Lee, was very different from a lot of periodontal practices in that my practice was internet-based. 80% of my practice came from the internet. And I had a website, and I very much actively marketed non-surgical periodontal therapy to the public through my website. This did two things. One is actually gave us good patient flow from the internet for periodontal therapy. At the same time, a lot of these patients had years of unmet periodontal treatment, of unmet dental needs. So this not only fed the periodontal side of my practice, it also fed the implant side of my practice, and also allowed me to refer a lot of restorative work out to a very select group of restorative doctors that I chose to work with, and orthodontists and endodontists. So it was an amazing thing. People are very, very excited when they know that they don't have to have periodontal surgery to treat their periodontal disease. They're so appreciative. There's actually a very visceral relief that they exhibit when they're told that they can be treated definitively without periodontal surgery. And I say definitively, I'll be talking about the protocol here in a little bit that I use in my office. Once we switched to the protocol, I had not really done a resective periodontal surgery or regenerative periodontal surgery to treat periodontal disease for almost 3 years.
Yeah, and the same thing for me. You know, obviously we do our crown lengthening, root reshaping, that type of thing. We have to do surgery for that,
Right.
implants and bone grafts and all that kind of stuff. And frankly, that's what this did for me, because all of a sudden the periodontal work was all being taken care of by my hygienist, and so I needed something to do. So I had to become good at bone grafting and implants and things like that.
Sure. And like I said, patients are very, very relieved. They're very accepting of this. They also just the fees. They're much more willing to basically come up with the money to get the treatment. People will work very hard to get this treatment to save their teeth or to get dental implants or whatever. But the acceptance rate of this is very, very high, simply because they are avoiding surgery, and they are really, really looking to avoiding surgery, and they're looking for doctors in their area that can help them avoid surgery. Now, one of the things that we do is I have this little piece of gum. What did I do? I hope I didn't eat it today. This is a spry gum that Henry Schein sells. I don't know if you can see that. It's a little packet, and this little TM is about an inch and a half. I'm sorry, 1.5 millimeters tall on this pry pocket. And this is what that TM looks like on the endoscope. On a conventional monitor, this will be about 5.5 inches tall. And this is a 100-fold magnification of this TM. When I show this to the patient, because we have a patient education material, when I flip it over and I show them, they're holding this piece of gum, I point out this little TM that they can barely see. And when I flip this over to show them this magnification, at that point they're like, oh, wow. They have just an incredible reaction to that, to the visual of the magnification. And at that point, you really almost have to stop talking. There really is no reason to talk anymore, and the arrangements are made for them to sign up and get treatment. So I've been doing endoscopic periodontal therapy for over 15 years. I think you're about 2000 is when I bought it, so maybe closer to 18 years. And when we first doing it, the first devices were very, very challenging to use. And we had lots of experiences. This was my $15,000 coat rack that I had. There are times that the hygienist would refuse to use it. There are times that they would cry about using this machine. And then I finally got a couple hygienists that were very, very excited about using this and became very good at using the scope. But the learning curve was huge on this. And then one of the reasons this never really caught on was the fact that the company had lots of problems. Service was bad, things like that, lots of things going on.
Now that's the old dental view machine. Of course, that's what we use, and we use that consistently. So we're
Yes.
one of the few offices that did use it consistently all the way through until that company came out with a better scope.
Yeah, and there's because I went to a meeting of a small meeting of endoscope users 2 years ago, and there were only about 100 of those scopes in use in the United States. And so that came from Zest, who was making the sheets at that time for that device. So this is the version. This is the OraView version of the endoscope. It has some wheels. You can get to go from operatory to operatory if you need to. Fairly compact and fits very, very nicely into the operatory. Now, when I talk about my learning curve, I don't know how what you did, Lee, but when I first had a scope in my office, we used to do traditional scaling and replaning, come back 6 weeks later, do a reevaluation, scope the areas that we did, and then see whether we needed to do surgery. At some point in my practice, we started doing endoscopic periodontal therapy on every patient that was basically 5 millimeters and above in our office that had radiographic bone loss. And over the times, we started adding various therapies. At this point, if I was still in practice, I probably would start using Periostat to basically get some of the inflammation down in the pocket, and has also to moderate some of the bleeding that occurs. I also use EMA Gain. I like EMA Gain. I use it. My use is off-label, and I'll discuss that a little bit here in a bit. One of the things that I like about the EMA Gain is that it outside the growth factors that are in there is that it prevents epithelial migration down the periodontal pocket. So it has an inhibitory effect. The tips on the EMA Gain that come with the unit, come with the syringes, are very hard to manage. I felt like I needed to grow a third hand out of my forehead in order to be able to use it, because I had to distend the gingival tissue in order to get it, because it's so thick. So these are actually little tips that people use for other things, for restorative dentistry, and from Ultradent you just get a bunch of them. I can't remember how expensive they are. They're not that expensive to get, but it makes it very, very easy to deliver the EMA Gain into the area that you're treating. I'm a big believer in oral DNA. A lot of times we have some very, very virulent pathogens. Using the oral DNA, take a saliva sample and send it off to a laboratory, and then they do analysis based on for the periodontal pathogens. Both a qualitative and a quantitative analysis of this. We did this. We were starting to do this after at the first reevaluation appointment, or I'm sorry, at the first maintenance appointment, just to make sure that our bacterial count was down. There were cases where we would have no bleeding or inflammation, and still the bacterial count would be relatively high. And so then that may be a reason why sometimes you get refractory periodontal disease. That's just speculation. Okay. Production, the business side of this. So if you're just doing traditional scaling and root planing, there's a ceiling essentially on what production is going to be in the hygiene department. When you start adding on these adjunct therapies, the EMA Gain and the oral DNA, that obviously allows your per hour production in the hygiene department to go up, and then also the sheath, which that goes over the fiber optic cable. That's an upcharge also that we did in my office. The learning curve for implementing this into your practice, I think on the newer devices is a lot shorter. I know that what we're figuring out is that with the OraView devices, between 5 and 10 cases, and it's pretty easy, and you'll see the videos that we'll be showing. Then we get into the insurance codes. One of the uses is to work around a dental implant to remove cement subgingival. There is a special code for that. I was talking to Tom Wilson, and he had mentioned something that was very, very interesting. That if you're going to do any endoscopic debridement around a dental implant to remove cement, you need to do it by hand. Apparently, if you use an ultrasonic instrument, it pulverizes the cement and drives it into the inner lining of the attachment. And they did some histology and they found that to be true, and so they really strongly recommend not doing it. In oral DNA, these are the codes for collecting a sample, for the analysis, all that. Typically we would do half mouth at a time, 1 to 2, basically 2 hours per half mouth. And these are the codes. This D1553, that's not a particularly code. That's a code that we made up to charge out for using the sheath for 2 hours. Then, of course, these are the traditional 4341 and biological material, which is the EMA Gain code. Lee, are you still there? Because I lost your picture.
Yeah, I just shut myself off so that you could be the star of the show.
Oh, okay. I just, like I said, I just want to make sure I wasn't sitting here talking to myself. I lost your picture. So these are the code. These are the insurance codes that we use. Again, appointment number 2 is going to be 2 hours again. Now, one of the things that we found is that as far as this EMA Gain, typically the number of carpules of the EMA Gain that we use was about 2. Usually 1 per half mouth. On rare cases, we'd get up to 3 or 4, or sometimes we have just 1. But typically, it was 1 carpule of EMA Gain per side of the mouth. Now there were cases. Some of the I'm sorry. Let me go to maintenance here. Again, 3 months. We don't do any probing on these cases until 6-month period. So we go. The first maintenance appointment is again an hour, and collect the DNA and do collect the saliva, do the DNA analysis, and through the sample. Sometimes there'd be so much calculus, it'd be so heavy, and pockets were so deep that I would give my hygienist 3 hours aside to do it, to do the endoscopic therapy. That wasn't real super common, but it did occur. It did happen. So the treatment, big benefits, done by a hygienist, and so in most cases, really does not require any additional time. I know there's some practitioners that actually can do a half mouth in less than the 2 hours. I think it also goes to how fast somebody works. People have different speeds that they work at. The ergonomically designed, this is really important for the hygienists because of how they sit at looking at the screen, and the fact also that all the work is done with an ultrasonic. There's no hand instrumentation done. EMA Gain, as I said, you have an upcharge in your hygiene operatory. I place the EMA Gain. I viewed it as a regenerative procedure, so I would come in and place the EMA Gain with those syringe tips that I showed you earlier. It was very easy. I don't think it ever took me more than 5 minutes to do that, to come in. So I could do that at the end of the appointment when on the hour, whenever the hygienist was done. Obviously, since you're not doing any surgeries, there's a lot less stress than doing it. There's not all sorts of blood going all over everywhere, high-speed hand pieces, all sorts of things, fighting a flap. All that is basically eliminated. Patient acceptance, really high. These patients that are coming in are looking for non-surgical therapy, and they're in many ways they have pre-sold themselves before they show up to your office, and of course, very minimal risk of infection. Sometimes, and I don't know how many. Sometimes, if we have somebody that's had lots of calculus subgingivally, and very, very inflamed tissue, sometimes you get a bacteremia. But that happens pretty rarely. But most of the time, it's a lot less common than it is with periodontal surgery. So this is a video of showing you, and let me just start off here. This white is white calculus. This over here is the tooth, and this is the gingival tissue. And so I'll just show you how it works in terms of coming off of there. And so it's kind of almost feels like you're down in the ocean looking at this. And there's water flowing through here to clean out and to wash out the calculus deposits that are being removed. And so you just basically have a real-time removal of these deposits, and you actually can see them coming off and being removed. And you have to be very methodical working your way around the root of a tooth in order to not miss places and be able to do this very, very efficiently to do it. And so there's a learning curve, but I think about 5 to 10 cases, and you should be pretty good. The practitioner should be pretty good at doing this. So Lee, that's kind of the brief overview, and I think we can start taking some questions here.
Well, there's a question coming up, and Mike Rethman asks the question: can you pose a few DNA outcomes that you've seen and how they've resulted in differing directions of subsequent therapy and patient management?
I don't have any access to those anymore. But most of the time, the recommendations on the systemic antibiotics were very similar. Every once in a while, there'd be some real outliers in terms of what was recommended. But I think what was the interesting thing was, even in the short in just a few sample, we found that about 40% of the patients that had been effectively treated with periodontal with the endoscope still had pathogenic levels of bacteria present, and that were detectable. So I think that for those reasons, that's why I'm a big proponent of the oral DNA test at that maintenance visit, after the first maintenance visit after the patient has been treated endoscopically.
And let me comment, because I do it differently. So
yes, I know. Yeah.
What I do, I violate the rules. What can I say? I run an oral DNA test on nearly every chronic perio patient before we do any treatment at all. Mm-hmm. And we find out that not 40%, it's a larger number, will show periodontal pathogens. We're probably at the 70, 80, 90% will show periodontal pathogens. It depends upon what I see there as to whether I'm going to choose to use an antibiotic or not. But if we choose to use an antibiotic, one precaution I'd give is that use the antibiotic on the day of treatment only, or start the antibiotic on the day of treatment, the day of using the scope. And the reason for it was, if we prescribe the antibiotic 5 days or 6 days or 7 days ahead, the pocket would be so tight that our hygienist could not get into the pocket. And so you wouldn't have the opportunity to debride. So, two different practitioners, two different ways of using the oral DNA test. So we used it prospectively rather than retrospectively. For me, I thought, just from a patient management standpoint, it's better to show them in advance what's going on rather than say, all right, we just did this and now you're doing a test and finding out that, oh, there's a chance of failure, or that something isn't working right. It's kind of a negative rather than a positive. And that's why I decided to use the oral DNA test right at the beginning.
Yeah, the 40% was actually after, and it was a very small sample. It was a very small sample. That was after endoscopic therapy. So that was the case there. Okay.
So I'll ask some more questions. Let's go to the marketing part of it. And we'll go into the endoscopic part of it, but the marketing part of it is where we started first. When you were doing the marketing, you said you did internet marketing. Now, a lot of people remembers the IDS because of marketing, or because they know that we can go direct to patient. So were there specific techniques or specific people that you used? How did you get a practice that had 80% of patients coming off the street?
Well, part of it is as in many things, and I'm going to say this here, being an early adapter gives you a real heads up on things. And my first website, I think it was like in, 2009, 2010. It was very, very early into the process. I'm sorry, no, not in 2010. What am I saying? Okay, I got my years. Oh, I know. No, I had a website in 1999. And so this was before anybody had some. So I have a lot of organic stuff going on in my website, and we continually added components, new content to keep it fresh and to keep the rankings really high. The other thing is that about 3 or 4 years ago, we made a big decision to go after Google reviews, and that proved to be very, very important aspect of keeping your website going. Audio, videos, I think are important. I had because of my name, people would call up and ask my manager where I trained. They want to know if I was foreign trained or trained here in the States. Patients would ask that. And once we put up the video of me, when you go into my website, the video of me would start me talking and welcoming people right away as soon as you got on there, and that pretty much eliminated that problem. But it personalizes it. I think you want to make it a very personable website and have somebody to manage it that does it well, because Google changes the rules all the time in terms of what they allow and what in terms of advertising. The other thing is that I had a lot of organic juice because I started so early with my website that it was really that's not something that would be available to a lot of people right now in terms of optimization. So you're gonna have to do paid traffic, because Google's designed for paid traffic.
It's true. Yeah. And we use paid traffic in our practice.
Yeah. Sure. Yeah, Google makes money on paid traffic, and they design it so it almost forces you to pay. It's almost impossible to get any sort of significant rankings with your website organically at this point in 2019.
Okay, so let's go beyond the marketing part of it now. Let's go into the diagnosis part of it. So and we talked about the oral DNA test and our different ways of using it, but what about diagnosis per se? Is there anything in particular that you do that might be different from what most of us do?
I don't think so, Lee. I think basically people come in, we do a thorough examination, probing depths, recession, bleeding points, furcations, all those things, a thorough medical history, find out if they're diabetic. We do just a traditional periodontal exam. And then in my office, sometimes most of these patients had so much deferred treatment that we hardly ever did a consultation right away. We almost always brought them back for a treatment conference. And at that point, that's when we sat down and had all sorts of things available to go with them. And had all our ducks in a row, all our presentation materials, any kind of videos. We used to have a video that would be able to show an animation of various procedures that we wanted to, but to have all that stuff ready for that patient. And then we used to also try to basically gear the presentation to the patient's disc profile, if we could figure it out. That was also an important thing in terms of case presentation.
Okay.
Because some people, just by on the various disc personalities, if you talk too much to a high D, they want to get out there. They don't want to be there talking to you.
So let's look then at the treatment. So you do the treatment plan. You're working with the patient, the treatment plan. First of all, let's go back a step. Are the patients that are coming in to see you, have they already been recommended for periodontal surgery and they were looking for another way out? Or, how do they know they had periodontal disease in the first place?
Well, in some cases, they would come before they had been to another periodontist. When they were referred, they would either self-refer, or they would either self-refer that they knew they had periodontal disease because they hadn't been to the dentist for a long time, or they would be referred to another periodontist, and they'd get on the internet and they'd find us, or they would actually have they would show up with the treatment plan from the other periodontal office and ask what we can do for them. So it happened in all different ways.
Okay. Is there then, because you were in Phoenix, so it means there's a large nucleus of patients that could come to see you because there are that many people living there and that many periodontists and, all the things you would find in a big city. How relevant do you think that is to your attraction in your particular area? Or could you do the same thing in a smaller town that you're doing?
I think you could do the same thing in a smaller town. We had patients that drove over 100 miles to get endoscopic periodontal therapy.
Yeah.
I mean, it was pretty amazing. I had people that drove down from Flagstaff, which is about 140 miles. Prescott, from all over the Phoenix metro area, which is it's a large. Phoenix has a very, very large metro area, and they'd be driving by lots of good periodontist offices, to come and see us for endoscopic periodontal therapy.
Okay. Now, you commented on the fact that you were an early adopter, which we were. I mean, we were the first ones in doing periodontal endoscopy. How many scopes are there on the market now?
Well, when I went to a meeting a couple of years ago, there's probably about 100 active users of the endoscope right now in the United States.
So that hasn't changed. So that was the active users. So we're still working on the number 100, which is the number that I'm working with as well. Yeah. Now there are two companies. There's your company and there's the other company.
Right.
So we hope there's going to be more market penetration because, frankly, it's good for patients. Yeah. But I mean, consider the number of dentists in the United States. What is it, like 200,000 or more?
Right.
And 100 scopes on the market. Talk about differentiation.
Yeah. Well, I think especially for periodontists now, this is being an early adopter here is a big marketing advantage, and just for the reasons that I outlined about how patients are looking for non-surgical periodontal therapy, and being the first in your neighborhood is going to be a big advantage to someone from a marketing standpoint, being able to market this.
Yeah, and we found that too. Certainly, people are approaching us for the exact same reason. Okay, so let's look at disappointments in therapy. Have there been disappointments, and how did you deal with them?
Well, just nothing works 100%, and there've been cases where we've retreated. I've retreated. There's some cases where they have not healed as well as I'd like to, and there are cases I can think of. One patient in particular where we had 2 teeth, and he had a full mouth of endoscopic periodontal therapy, basically all 4 quadrants. And there were 2 teeth that I would probably, had they been standalone, I probably would not have treated them periodontally. I would probably have removed them and done dental implants. But since we were doing it, we did. We ended up being able to save one of those teeth, and the other one we were able to save. So yeah, it's not like, I'm not going to sit here and tell you like everything works 100% here. Yeah. But at the same time, we got some tremendous results on a lot of patients.
Great.
And especially the fact that you don't lose soft tissue height in the anterior area, especially. I mean, you do surgery in the anterior. I mean, I've tried. I've done all the papilla retention. Coming in from the palate with a minor little incision, and all of that stuff, and you still end up losing interproximal soft tissue and end up with a black triangle. With endoscopic periodontal therapy, that just really does not happen, and it's a big advantage to have that.
That's true, and you want to see a big advantage. Take an aggressive case on a younger patient, treat them appropriately with the endoscope, with antibiotics, and watch the bone grow back. I mean, you see these, these amazing things that the laser companies, for example, will show in their advertising. You can see the same thing with with this kind of treatment.
Yeah, yeah, it's pretty amazing.
What about periimplantitis?
You know, as I said, you can go ahead and treat that with an endoscope. Most of the time, when I had problems with implants, a lot of times I was fortunate because I was working with a very small group of doctors that I referred to, and so all of them knew how to make a proper custom abutment. They knew about, I actually had a hands-on prosthetic implant study club for about 15 years, and it was taught by a prosthetist, so I had to come down. And so we spent a lot of time on proper custom abutment. So, but when I would get a case that would come in from, let's say, from out of my group, invariably I found that a lot of times it was a problem with the custom abutment design, and so we would end up redoing that and making it properly so it's pretty close to the gingival margin, and you don't get a lot of cement trapped below. The other thing is that for my purposes, when I had problems with an implant, with bone loss, things like that, I ended up using a lot of times growth factors, PRP, and things like that to treat, and I found those to be very effective.
All right, good. I'm out of questions. Anything else you want to add to this?
No, I think you covered it. I just would say that you know, this is going to be, it's coming in a significant way into the dental community, and I think it would behoove periodontists to be early adapters here, to be an early adapter of this technology. In some ways, the old devices was an idea that was not in sync with the technology existed, and the new device, I'm going to say device because obviously I have a bias here, is technology that it's an idea now that technology is finally caught up to where it needs to be able to support the idea and the concept of definitive periodontal therapy without periodontal surgery.
Terrific, Orest.
Yeah.
Dr. Orest Komarnitsky. Orest, great to see you again.
All right, Lee,
whether
thank
we see
you.
each other in person or whether we see each other like this, to have somebody who shares my thoughts, boy, I really like that. That makes me feel pretty good.
Well, yeah, we're two out of a few. two out of 200,000.
So let's get some more. And for all of you, thanks for joining us for this webinar. Next webinar will be it'll be on March 13th, and that will be with Dr. Brian Bensing. Brian is a general dentist in Chicago, and he is just an expert on case presentation, large-scale case presentation. So he's going to get into really a good session with us. I think your staff will benefit from this, because he will not just get into case presentation and the mechanics of case presentation. He will show you how, with the appropriate case presentation, patients will ask for more treatment. It's kind of unique, kind of different, and we'll get a lot out of that. And that will be on March 13th. It'll actually be a two-part. We'll probably record both parts on March 13th. So plan on being with us for 2 hours, but of course we'll split it up into two sessions. So those of you who are not on live but are looking at it on the podcast will be able to see it in the podcast in bite-sized sections. So Orest, thanks again for a great session.
Thank you, Lee, and you have a great day, and look forward to when we see you in person.
Thank you. Thanks, and we'll see you all soon. Good night.